He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Okay, so we're live. This is the Stay Off My Operating Table podcast. We have today a special guest I'm looking forward to, Dr. Kwadwo Kyeremanteng. Phil, are you impressed with me pronouncing it that way?
I am, and I'm not going to try and recreate it. So,
okay. So for those of you who are reading his name, you're going to say, "Oh, Jack, you pronounced it wrong," but I did not, did I?
You nailed it. I told you earlier, my mom would be so proud of you throwing that down. There's like 22 million Ghanaians that are cheering in hearing you pronounce that. Jack, you're a legend right now.
Well, my mastery of Ghanaian is legendary. So. Okay, Phil, tell us why this dude's on your show.
Well, as you can already tell, he's a lot of fun. So that's reason number one. He is and I'll let him do the full introduction, but he is a critical care physician north of the border in Canada. And I was just real fortunate to meet him at a conference not too long ago. And, we got to talking, and Kwajo has the mindset that we talk about so much on this show, and the outside the box thinking when it comes to lots of things around medicine and nutrition. And I'm going to be excited to dig into all that with him. But first, let's give Kwajo a chance to introduce himself to the audience and tell us a little bit about what he's been up to.
Oh man, well, I'll just tell you straight up, Phil. That intro was legendary. I feel like I can't do it any better than that. But yeah, essentially, I'm an ICU doctor north of the border, department head at the Ottawa Hospital. Host a podcast myself called Solving Healthcare, and what got me into this space was the pandemic, and seeing how metabolic disease was a huge driver of poor outcomes. And when you start to dig into people, like learning on ways that people can reverse disease, which is foreign to me. And that's why when I heard Phil on a podcast and hearing his story, and we just had so much in common, that idea that it was novel to hear how you could reverse type 2 diabetes and with all these different lifestyle approaches, and seeing the benefit for himself and for his patients. I just got super passionate about this. And yeah, so for me, it was really the pandemic that was a big driver in terms of learning about a lot of this content. And I also do a lot of research on healthcare utilization, like looking at ways to reduce healthcare spending. And so I do a lot of focus within ICU. So different medication, different approaches to care, how you save money that way and improve outcomes. But then when I look at this, the most efficient way of saving dollars is preventing them from landing in the ICU. Really, if you can prevent yourself from walking in the door and not, get significantly disabled, malnourished, have the mental health issues that many of our patients have, and that kind of overall, the impact that you have on your own family because they have to take time off work, all these things, if you can prevent them from walking in the door, that's where the money's at. And so when even the title of, the Phil's book and everything, when we got a chance to sit down in Santa Barbara, I'm like, this is my man right here. This is my boy. And so we had to connect.
Yeah, definitely. Let's, a lot to jump into, but let's start with, your podcast is called Solving Healthcare, and it's a great podcast. Certainly recommend it to everyone. But, tell us about the title. What are you trying to solve?
Exactly. I was wondering the same thing.
Well, the thing Phil and Jack, it was you when you are involved in healthcare, you realize it is extremely inefficient. There's so much to remedy. The delivery of care, as I mentioned, the efficiencies, the lack of innovation. There's just so many gaps, and so my whole purpose was to kind of empower the healthcare provider, empower the patients to say, hey, there's a lot you could do for yourself. There's a lot you could do to improve your situation, what you eat, exercise. In terms of healthcare providers, how do we educate our patients? Like, how do we reach them? How do we, have that individualized approach to medicine and give people the tools to be able to provide better care? And so it really, a lot of it is awareness, like putting a lens on some of our soft spots, and then having that discussion on how we remedy these things. And I'm a doer. Like I recently started as a department head at our Department of Critical Care, and my whole mandate is we're going to make some changes. We're going to improve care delivery. We're going to be more efficient. We're going to reach out to more of our patients and provide better care than we are providing now. And so, that's the anthem of the show.
You've got two classes of listeners to this show. You've got folks like me, who just a guy who's interested in being healthy but no healthcare background, and then you've got healthcare professionals. So I would like to ask a question as a guy to two healthcare practitioners about what you just said. You're in an ICU, an intensive care unit, and you've had this revelation that the best way to have better outcomes is to never end up in the ICU, and the best way to never end up in the ICU goes back to what Dr. Ovadia talks about, metabolic health. I would like each of you to comment about, and I want to be careful how I frame this, because I don't want to get anybody in trouble, but that perspective is not the majority opinion amongst healthcare providers. How does that affect your practice of medicine? Each of you. I'm interested from both of you.
Should I jump first?
Go ahead.
You're the guest.
So I mean, this is why we're having the conversation now. Like, I think this is not common practice. It's not a common mindset of really focusing on prevention. A lot of our studies, our lectures, our treatments, everything is surrounded by sick care. Like, how do you deal with the patient when they're sick? And don't get me wrong, this is vitally important. I got off ICU yesterday, and we resuscitated a bleeding patient, and our skills is what saved that life, to be able to, intubate, put lines in, and do all the things that the patient needed. Super important. But the question is, let's talk root cause. Let's talk about why that patient landed there. What can we do to prevent that from happening? And it's a pivot. And this is why platforms like this, about going on, doing a podcast, going on social media and talking about these issues, in my opinion, can serve to inspire, to bring awareness to some of these issues. And the thing about someone like Phil and myself, we got the street cred. We've seen the damage that people go through when they land on his table or they land in ICU. So that voice is so important. And my goal is to motivate other clinicians to see the same. Like, really, realistically, ask yourself, why is the patient landing here? Like, we've given up in so many ways. We've just said, oh, you know what, they're diabetic, let's add some more insulin. Let's add more and more insulin, even though this is making them more, perpetuating the problem. Let's start thinking again. Like, I feel like we've lost the ability to think critically and take a step back and say, what is actually happening here? And let's look at this root cause and attack it that way. And it starts now. It starts with conversations like we're having today.
Well,
Yeah, I think that
I want to know, are you getting static from within the healthcare industry for taking this stand? I know Phil does.
Maybe, I guess one of the approaches that we've done, like one of the reasons my research program is focused on cost savings, is because that's the currency, no pun intended, that the decision makers like. So when you could show that an intervention will reduce spending, it's hard for them to ignore that. It's hard for them to say no to an approach. It's, and frankly, I'm sick or tired. Like, I don't care what people think. Like, like when we talk about like one of the things that, I don't know if you've experienced much of this, Phil, is when you talk about the poor metabolic health amongst our patients. Like when I was saying, like, we were seeing tons of obese COVID patients, and people would be like, you stop fat shaming. I'm like, it's not fat shaming, it's reality. If I was obese and if clinician had a chance to tell me this is a risk factor for landing in a hospital with COVID, I would want to know this. Okay. And that was my approach. Like, and so you can say all you want. I mean, you can't please everybody. There's going to be haters no matter what you say. But I got to look at the end of the day, look at myself in the mirror and say, am I making the right call here? Am I making the right statements? And I have no problem approaching it this way.
Yeah, I agree, and I think that physicians have abdicated their responsibility, on many fronts. And, we saw it with the pandemic, and we see it with the whole metabolic health issue. And, this whole concept that physicians shouldn't, or physicians can't help people to be healthy is just, mind blowing. I mean, people, I get pushback because I'm trying to keep people off my operating table. And, it's like, well, isn't that what every doctor should be trying to do? Every doctor should be trying to make themselves less busy because that means that people are staying healthy and people don't need our, services as much. And that really should be the goal. And really, from the healthcare system perspective, that should be the goal. And, I'd actually like to hear your perspective because, you're in the Canadian system, which is a socialized system. And so, there is a set pool of resources that can be used. And that needs to be distributed amongst, all of the people who are using healthcare services. Whereas opposed to here in the United States, we are driven, our healthcare system is driven by revenue. The more we do, the more everyone makes and the happier everyone is. So there may not be that same incentive to keep people from needing healthcare. But it would seem that a system, like Canada has, like the UK has, they should be very much in tune with these preventative efforts because that fits in their model perfectly. So I'd really like to hear what your perspective has been on that, from the Canadian healthcare system.
It's a great point, Phil. Like, I think people they buy in on paper. They like the idea of making your city more walkable, having more access to quality foods, really thinking about being more active. All these things on paper, people want to see. The problem is, for any government that lasts usually about 4 years, a lot of this upfront investment takes years to pay dividends, and so they're trying to make. Their focus is on how do we reduce surgical wait times, how do we improve cancer screening, and all these things, which are obviously really important. But I think a lot of the attention is still on the acute care because they want to be able to show some impact in a 4-year cycle. So it's still well received. It's just a matter of us being a little bit more long-sighted, or farsighted, I should say. But like, for example, a classic thing that we see in hospitals frequently is, I always say one of the most important allied health professionals is your physiotherapist. And unfortunately,
what's a physiotherapist? What's that?
So a physiotherapist is a healthcare provider that helps you rehabilitate, to get you stronger again, to get you out of bed, to get you breathing better. And unfortunately, they're one of the first positions that get cut often when budgets are tight. And in my opinion, they're going to get you out of hospitals quickly. They're going to get you out of hospital faster than if you didn't see a physiotherapist. I see the magic of their job daily in acute care and in the intensive care unit. But we want to balance that budget. So to answer Phil's question directly, there is engagement. It's just we're not seeing the level of commitment that is going to really put a dent into things yet.
So I'd love to hear what Phil's doing. This stay off my operating table stuff exists entirely outside of how he practices medicine. When Phil's practicing medicine, he's got a scalpel in his hand and somebody's laying on a table. So this mantra of get metabolically healthy really doesn't involve his practice of medicine. I'm saying that right, aren't I, Phil?
In somewhat, yeah. I mean, obviously, when I'm doing surgery, that's a whole different thing than trying to keep people from having surgery.
Well, I realize that what you're doing
when
is
they come to me,
a type of care.
When they come to me for surgery, it's time to do the surgery and do the best job we can do at that. And then, my hope is after that, we can then address what led to them needing the surgery in the first place.
Okay, well, that probably dovetails with the question I want to ask Kwajo, which is, in the ICU, how does this message of get metabolically healthy manifest in how you practice and in the type of care that's delivered? I've heard horror stories from Phil. I don't remember if we've talked about them on air or off, about walking into a patient's room after he's done surgery and seeing this carbohydrate bomb sitting on their cafeteria, on their
I was
tray.
just gonna say that.
Okay, well, how does metabolic health, how do you deliver that in the ICU? What's step one, and how does it work its way through?
So, Jack, I'm gonna unfortunately not have great news for you, but it doesn't play out easily. Like really the priority when our patients come through is just really, like, often they're on the brink of death. So we're trying all we can to recover them. But as they're getting better, my personal opinion is where we could benefit is how we feed our patients, for example, and just represent the change we want to see. So, for example, I think you hit the nail there, Jack. Like, we feed our patients like the food. So when you're in the intensive care unit, you obviously can't eat. So what we do is we put a tube that goes from your nose into your stomach, and then we put nutrition in that way. And it is it's heavy in seed oil, it's heavy in carbohydrates, and we just accept that as the norm. And as you're getting better, if you're able to eat your own food or whatever, it's not going to be the healthiest thing you've ever seen. It's going to be focused on carbohydrates. I've seen even some diabetic menus. I swear I've seen French toast on there. And so I think this is where I want to see us pivot is, as you're leaving, as you're getting better, that we have that kind of educational piece and give less pro-inflammatory food. Like, ironically, Jack, when you land in hospital or specifically in the intensive care unit, for most reason, it's driven by inflammation. COVID, like, for example, you come in with COVID, in the second wave, third wave, if I were to swab your lungs and try and find COVID, you probably wouldn't find a live virus, but it's just the inflammation response is what caused you to be so sick. Same with pneumonia, same with even other like brain conditions, all driven by inflammation. And what do we feed you? Pro-inflammatory foods. So our research group is starting to kind of push the idea of seeing if we could, for example, have some fasting time during the care in the intensive care unit, seeing if that would have any impact. We're also looking at lower carbohydrate feed to see if that could maybe have a more positive impact on patient outcomes. All this is very slow moving, but it's on our agenda. But it's going to be a while before the needle is moved on this one, though, unfortunately.
Phil,
Yeah,
throw the ball over to you. I want to hear the same comment.
Well,
comment
yeah,
on the
I
same
mean,
question.
I think, similar to what I was talking about around surgery, the other opportunity is for us as physicians to have that conversation with the patients, with the families about why did you get here? Not just, oh, you have COVID or, oh, you have pneumonia, but what was the root cause for that? And we just don't do that as physicians. You could say we're too busy trying to save your life. It's certainly, when I'm in there doing the heart surgery, my focus is the heart surgery, and no one expects me to then sit down with the family and say, okay, we did the heart surgery, we got you through that, we have basically put a Band-Aid on the problem, so it's not going to be as a life-threatening issue for you anymore. But if we don't talk about why you got here in the first place, you're going to end up back here. And Kwajo certainly knows that patients who are in the ICU once are at high risk of ending up in the ICU again. And it can be for the same problem, it can be for different problems, but the fact that you ended up in the ICU means that you have, significant underlying health issues. And then you got something on top of that tipped you over the edge, and now you ended up, in critical care. But if you don't address the underlying problems, something else is going to come along and tip you over again, and you're going to end up back in the critical care unit.
So what's happening in medical care? And here's where my ignorance of the entire thing is going to display itself. But as a guy who's been interested in staying out of hospitals and staying off of operating tables for a long time, I'm deeply interested in how this message will get through. Is it getting through? What's happening to get it through? Are these podcasts and these kinds of things, is the best way to make it happen? Is it starting to propagate throughout the system? Are you seeing progress from your colleagues? How is this working?
I mean, I must say this is one of the unintended blessings of COVID, is that really it was undeniable that this was a huge driver. And a lot of people were, because of how scary COVID was.
Undeniable by who? Was it the people there working in ICU who could it was just obvious as healthcare providers? Poor metabolic health is, that's who?
Yeah, it was a good question. So all like the healthcare providers, by the medical literature, like now it's very well established studies showing a link between poor metabolic health and COVID outcomes. And, this has been the center of attention for so long that, this is one of the spinoffs is how do we get healthy? How do we talk? Why is it so important to get us healthier? And then on top of things, Jack, over the last whatever, to a couple of years as well, people have gotten worse in terms of their metabolic health.
Right.
You know, because they had the COVID 15 or 20 pounds that a lot of people added on. You know, it's, you know, I recently even had a patient that just, you hear these stories about, you know, when they isolated themselves and just haven't been able to get back to where they were. And so, you know, I do think the message is getting out there. I think it's trickling down. I do think by these formats, by even presenting some of this stuff in medical conferences, formal medical conferences, I think it's hard to deny, and automatically when you present this kind of data, people always have, it's our nature to say, like, what are the solutions? You know, even though
Sure.
we might not be asking about root causes, but people will still be asking, like, what do we do? So, you know, is this enough to move the needle? I don't know, but I know personally up here in Canada, we've been highly motivated. I've connected with as many public health figures as I can to talk about these issues. I've encouraged them to talk about, for example, making our city more walkable, making it in vogue to talk about health and wellness.
You live in Canada. It's cold in the winter. Nobody wants to walk.
Oh my goodness.
Come on.
You know, I make the joke because I'm like the only I don't know how PC this is, but I'm the only Black person I've ever seen cross country ski. But it's like when in Rome, you know what I'm saying? But
didn't mean to take us off course there, but I hate cold weather.
But yeah, it is pretty challenging to keep moving in the winter. But you know, as Phil, I'm sure, would allude to, there's other things like in the winter, if you're not outside, you know, maybe we're thinking about what we eat, making sure we have good connection with folks, you know, because all these things I think contribute to our overall well-being. Get to the gym if you can. I'm a huge fan of resistance training, but yeah, I'm hoping this movement is moving the needle, and certainly it's not slowing me down regardless.
Yeah.
Well, go ahead.
You know, I would just say that I'm optimistic by, you know, seeing the increased presence of doctors at, you know, some of the conferences, the metabolic health conferences, the low carb conferences, you know, just seeing the number of physicians online that I interact with now, and, you know, that are contributing to the conversation. And we look at the organizations like the Society of Metabolic Health Practitioners, which is doing a great job of bringing together the physicians that are interested in this and getting resources for those physicians to draw upon. So that certainly gives me hope. I think on the patient side of things, you know, for the people, they're increasingly getting the message as well, and the message is resonating with them. So, you know, I now have people who come to me, you know, who end up, you know, seeing me as a heart surgeon, and they're already talking about, you know, metabolic health, and you know, some of them have read my book, a lot of them haven't, and, you know, they'll come to me and they'll be like, oh, I know I have heart disease, and, you know, I've been reading, and, you know, it's sugar and carbohydrates that are causing this, and we're starting a low carb diet. And then, you know, so I do think the message is getting out there, and I think it's getting to the people that need to hear it, but we certainly need to be doing a better job of it. And quite frankly, I think one of the biggest barriers that I see, which is the challenge, you know, for Kwajo and I, is that it's oftentimes other physicians who discourage patients from doing this. And, you know, we have to try and increase the acceptance that at least this is a valid treatment option, and get that acceptance from our colleagues to be able to support these patients.
Like, can I give a quick example? Like, if you were to ask, I don't know, 100 docs, including docs that specialize in diabetes, if you could reverse type 2 diabetes with lifestyle modifications, low carb, keto, or what have you, I don't think many of them would think it's possible. I know I didn't. And these are the ones that are managing the patients. So yeah, there's still a lot of work to be done, that's for sure.
So let's I do want to get into how you sort of came around to this, Kwajo, because it is so interesting that you didn't really come at this from the nutritional standpoint. You were seeing all of these patients with COVID and seeing the effect that poor metabolic health had on them. And then, kind of tell us what happened from there that got you here today.
Yeah. So I guess what was, it wasn't that in the first wave, we weren't getting a lot of information about risk factors and so forth, but it was abundantly clear within the first couple of weeks, like every single patient, most of the patients are either extreme of age, have a poor immune system, or they have poor metabolic health, and despite age. And so this was, to me, such a loud message, to the point that even one of our docs, so one of our ICU docs, lost 30 pounds through mostly fasting and low carb because of what he was seeing on the front lines.
Someone's at the front door.
Sorry about
this
that.
is live, folks.
Because of what he was seeing on the front lines. And so as I'm seeing this, as I'm learning about this, and then I start to interview some folks that were mentioning things I never heard of: reversing metabolic disease, think about intermittent fasting, think about low carb. So I started to interview Jason Fung, Rob Wolf, sorry, I'm totally brain farting. What was his name?
Yes,
Sorry.
even physicians can brain fart.
Diet doctor, Brett Scher.
Yeah,
And,
Brett Scher, yeah.
Yeah, and I was like, why don't I know this? And why aren't we telling everybody this? This is the time, the time is now. This is before vaccines. I'm like, want to reduce your chance of getting sick? Let's talk about getting healthy collectively. I was thinking the summer of 2020. What if that was the public health message? Get outside. Let's get healthy. Think about what we're eating. Focus on whole foods. Let's do this together. What a powerful message. You're going to reduce your risk of COVID, cardiovascular disease, strokes, cancer. All these things are being impacted by us being motivated to get healthy. What a beautiful movement that could be. But it was crickets. It really was crickets. And so I was, tell me we can't do something. Get me motivated. I was like, hell yeah, let's go. So, coverage on the show, any new media outlet that would hear me out, I would let them know what we're seeing. And once you see it, you can't unsee it. That's the thing. Like so you do your own research, you do your own deep dive into some of these topics, and it's hard not to get excited about it. It's hard not to not preach. And so I was a man possessed, and by no means have we put a significant dent in a lot of this, but when you have a platform and this message can impact lives, not only just the direct patient, but when people get healthy, it amplifies. When your loved one, oh, hey, last time I saw you, you were like 30 pounds heavier. You look so good. What are you doing? Oh, I started to do some low carb. Have you listened to that podcast with Dr. Phil? You know what I mean? Like this is what we got to do, especially in light of COVID and all these things. Yeah, it just amplifies. And so that's a long-winded way of answering that, but it's just like I must say, it was so eye-opening. I couldn't believe what I was hearing. I couldn't believe that people are reversing type 2 diabetes in weeks. In weeks. And we're not talking about this. It's crazy. I still think it's crazy that it's not common knowledge. You know what I mean?
Yeah. Oh yeah. I mean, it's, and the data again is out there. Verta, has published their results.
Yes.
They've published now their longer term results. And, that should have been front page, on every newspaper. And it, like you said, it was crickets. I mean, it ended up in some, in a journal that's not as highly regarded, and there was no media coverage of it at all. And, again, then you have to start asking the questions why that is. I mean, why wouldn't this be publicized? Why wouldn't certain institutions, let's say, want this information to get out? And like I said, I think it's incumbent on us as the physicians, to step up, to take responsibility, to, make sure that we are serving the patients first and foremost. And unfortunately, I think for a lot of physicians, if they took a long, hard look in the mirror, they wouldn't be able to say that.
Amen.
On behalf of the patients, let me just say thank you, guys. I love it that's because, with demand from the patient side, people like me, and supply from the physician side, people like y'all, the external pressures that are keeping this message suppressed are going to begin to crumble and corrode and fall away. And yes, it takes time, but I'm just deeply appreciative that you guys are doing this. It's so much fun to see. It's like it's gaining momentum. We've been doing this podcast a little over a year, Phil, is that right? And it's just extraordinary to see lives changed, people transform themselves as a result of physicians like you and Dr. O exhibiting the moral virtue of courage and standing up and saying, hey, this is the truth. I thank you. I appreciate it.
That's very kind of you. I just, at the end of the day, I think, Phil, you feel the same way. You got to be able to look yourself in the mirror. Like, your compass for making decisions is in your values, and my values is always personally along do the right thing, justice, be courageous. And I know Phil has felt the same. We both have taken heat in different ways, and but at the end of the day, I could honestly say we both could look at ourselves in the mirror and say we're doing our best.
I would like to make it a little more personal. I only know you now at this point from the chest up, but from what I can see, you're fit. Yep. He's fit farther down. Oh, look at that. Got a gun show going on here, folks. Have you always taken care of your body? And the reason I ask is because, Phil's story. Yeah. He was an obese heart surgeon. So he had to come to Jesus moment and had to take extraordinary steps to change his life. What about you? What's your story personally, physically?
Yeah, to me, thanks for the question, because it's actually being functional and fit and active has been just cultural for me. It's been part of life. I grew up playing hockey, tons of sports growing up, and
a lot of hockey in Ghana.
Actually, I was
I'm sorry. I had to throw that in.
Yeah. But I was actually born and raised in Edmonton, which is a huge hockey town. I don't know if you know much
Wayne
about
Gretzky.
Yeah, there you go. So we had a lot of cups coming our way growing up, but being active and being able to perform was huge.
Well, you couldn't have played hockey very long. You've got all your teeth.
They're not real.
Oh, okay.
No, at that age, you still played with a cage. But being active is so important, and always asking yourself how you can optimize performance and be as ready to play. And then after you stop playing, you still want to be active. You still want to be able to, go on that hike. You want to be able to ski with your friends. And so fitness and nutrition. Sorry, fitness was always a priority. Nutrition wasn't a priority till you get to that age where I think it was residency, really, where you realize you can't just eat whatever you want anymore. And you realize, hey, what you're eating can affect your mood and your energy levels. And so I started probably soon after I finished residency to actually be more thoughtful in what I ate. So I maybe wasn't fully low carb, but I would be lower carb. And then about 5 years ago, I started intermittent fasting as a father of three, busy lifestyle. This was just the best way to maintain, I thought, my weight. It was just skip breakfast, time restricted eating. But yeah, my being mobile, being fit is like almost part of my identity, I feel. And so and I love it because I have 3 young sons, and like we do everything together in terms of the oldest wants to work out with dad. You might hear some basketballs being shot outside, or shooting the puck outside. Like we like to move, keep the boys moving. So it's so important to me to be functional. And so yeah, that's been a huge part of my life. I love it. And I could talk fitness and nutrition all day.
Was there an aha moment for you with your own personal health and this revelation of metabolic health in the ICU, or was it all just did it just happen slowly and organically? What was?
Yeah, it was a bit organic. Like it was a bit slowly and I guess it's relative. I guess it was in a matter of weeks, really, after being like
pretty fast.
Fair enough. Like when you're in the ICU dealing with the COVID stuff, especially in that first wave, like we were all pretty frightened. Like I wasn't sure, am I bringing COVID home? You see all this stuff happening in New York and Italy. You're wondering, are we going to have a similar situation? So your head is there. And then as you've noticed, like you're protecting yourself, you're not bringing COVID home, you're not seeing healthy people getting sick. That's when it started. When you got to reflect, the wheels started to turn. And really, once you see it, as I said, you couldn't unsee it. And then you hear about these ways of reversing disease. And so it was almost like an obsession. And, I've done some modifications to my own diet since being woke, if you will, in terms of,
let's say awakened.
Yeah,
we're going to leave the other word for other people.
Yeah. I really like that. But yeah, it was like I tried 2 weeks of keto, for example. It didn't jive with me, but I've maintained a lower carb approach. I continue to intermittent fast. I feel like my body's a well-oiled machine on that way. I haven't done carnivore yet. I might want to try that just to see what it's like for me. Like
we have a resident expert.
Absolutely. Because one of the things, Jack, that also has been enlightening in my opinion, and this took some time to really refine for me, is thinking that really when it comes to nutrition, it is personalized. Like what works for Jack might not work for Phil, and really trying to find what works best for you, I think, is where the expertise and the what makes a good clinician, not just having that cookie cutter approach, saying everybody needs to be low carb or keto, or it's what actually works best for Jack. And that was another enlightened revelation as I've been navigating through all this nutrition journey.
Tell us about your podcast. I love this. I love the. I'm going to say this, and this information will be on the show notes. But your Twitter handle is, well, Quadcast. I love that.
Yeah, there you go.
Tell us about your Quadcast.
Yeah, no, I appreciate the love. It's spawned in 2019 and it came from our research program, when we noticed that, you're producing all these research papers, but nothing is moving the needle. Nothing's changing. So we thought to ourselves, what's a way of amplifying some of these messages? And so we thought, hey, you know what? I love podcasts. Let's try doing this. And I won't lie to you, Jack, ever since September 2019, my life has completely changed. The people I've met, the topics we've covered, being department head, being on the board of governors for our kids' hospital, starting a charity called Bridges Over Barriers, with all spawned from the show, meeting Phil at the Metabolic Health Summit, all were derivatives of being passionate about healthcare and talk about ways to empower patients and healthcare providers to provide optimal care and think outside the box. Remember, again, to think critically and don't shy away from thinking outside the box, and encourage thinking outside the box. That's what we're passionate about. And honestly, I mean, you guys are about a year deep into this, so you could probably say the same thing, but wow, what a life-changing event from deciding to go on this journey.
It's been huge for me, and I'm just, I'm the talking hairdo. It's so much fun.
Isn't it?
So who's the target? Who's going to enjoy your? Sorry, Phil, I'm yammering here. Who's the target audience for your podcast? Is it healthcare practitioners? Is it average Joes like me? What is it?
The ideal population that we were targeting is healthcare providers, but we speak in that language that your mom can understand what we're throwing down. Awesome. I really wanted to make it universal language, even though the topics I really want to target healthcare providers, because in my opinion, they're amplifiers. If you have a family doc, all of a sudden that buys into low carb, wow, that's like how many patients now that can be impacted. So, when we marketed the show, is to medical students, residents, family docs, nurse practitioners, all the people that could potentially, we call it on the show, changing the boogie. You know what I mean? Like changing the narrative.
Boogie.
Yeah,
I love
it.
The
boogie.
Yeah, getting to medical students, I think, is a huge part of this. Getting to the early career physicians. How do you encourage your colleagues to think outside the box? You're a leader, you're a department chair. But so much of the training in medicine these days, so much of the mindset is staying within the lines, evidence-based and following the guidelines. So what do you think we can be doing to get our colleagues to think outside the box more?
So there's two approaches that I use to try and get more of us to think outside the box. One is just constantly asking tough questions. When it comes to cholesterol, for example, if you just ask the tough questions and say, like, what study are you referring to? And I'm like, have you looked at that study? Why don't we go over it and show me where you think, these cholesterol figures really are correlate with poor outcomes, like really pushing the envelope and then at the end of the day saying, like, well, maybe it's not as obvious as we think it is, or the picture isn't as clear as we think it is. That's number one. Number two, I don't know if it's lazy or what. I just act. I just like try and be the example. I'll be like, yes, you're hearing this. You hear what these problems are. I often will propose or do a pilot project to try and prove that our approach will work. I just lean on action over like trying to change people's mind through verbally. Data. Let's, what I say, like, I hear you, we're just going to do this, we're going to hustle, we're going to show that it's going to be effective, and always, as I mentioned before, have a cost twist on it, show that whatever we're doing is going to save money and improve lives.
So that brings back a question that I wanted to ask earlier, but didn't. You talked about your research. You're actually conducting studies in the ICU? Is that right?
Oh yeah, yeah. So that's
I had no idea that was even a thing.
oh yeah, big time. Like even there's approaches to say when if you had COVID or pneumonia, there's ways that we know to settings on the ventilator that we know that will improve your likelihood of survival. So, studies have been done on that. Studies have been done on types of medication if you're really sick with an infection. Different medications, medical infusions to see if they will improve your outcomes. Giving, for example, steroids, that's a common one that we've studied many times to see if that will improve your outcomes whether it comes to pneumonia or severe infection. So we do studies all the time. In fact, once again, I just finished ICU yesterday. We enrolled two patients in separate studies. It's a heavily studied specialty for sure.
So yeah, and Jack's question actually kind of shows, reveals, I guess, maybe one of the problems that we have, in that people expect that everything we do in medicine is like proven and kind of textbook, I guess you would say, that we all just have the textbook, and doctors are so good at being doctors because they read the textbook, they memorized the textbook, and that's what makes you a good doctor. And the reality is that, every patient is unique, every situation is unique. And in order to be a good doctor, you need to be creative. No two operations are ever the same for me. And sure, there were the basic, skills and the knowledge and the anatomy and the physiology and all of that that is common to humans. But every patient that shows up in front of you is a new situation, is a new patient. And this is what has made doctors so successful. And yet in today's environment, that is now being actively discouraged. That we shouldn't be thinking outside the box. We shouldn't be thinking for ourselves. Just follow the guidelines, is the mantra. So I think that's such an important point. And I think, Jack's question, just revealed that Jack was thinking, I'm assuming, and I won't speak for Jack, but that you shouldn't need to do research in the ICU because you should have all the answers. We should know what to do, but the reality is we don't. And things that we think are the best way to go about things. Again, we saw this early in COVID. There were things that were tried and things that were assumed to be good because for other similar diseases in the past, these are the things that worked. And all of a sudden we saw that they weren't working and they were, harming people. And, that meant we had to pivot and think of some other things to try and to experiment on and see what worked. And now, thankfully 2 years, 2+ years into treating COVID, we're a lot better at treating COVID than we were 2 years ago.
All right. I have one last question. And this, I heard you use the phrase evidence-based, and I used to date a nurse. She was actually an ICU nurse. And I heard the phrase come out of her mouth. And I had a critic of Dr. O DM'd me on Twitter, and his criticism was that he used evidence-based medicine and Dr. O doesn't, or something to that effect. And as a layman, my assumption is that evidence-based means there is evidence that this works, or there is evidence that that doesn't. I'm not altogether sure my understanding of how healthcare practitioners use that phrase, however, is accurate. What do you mean when in medicine you say this is evidence-based? What does that actually mean?
So what it means is if they're using, quote unquote, the best data available to guide their decision. the problem with just evidence-based, evidence-based decision making is a couple of things. It depends on the quality of the data. Like, is it a randomized controlled trial? Meaning, like, is it the highest quality of studies that we're using? And second part that we're, I think as the years go on, we're going to approach this a little bit different. What a lot of the people in the study, for example, in ICU, might not be exactly that patient in that study, if that makes sense.
Right,
So if
sure.
do you know what I mean? Like, they might be slightly older. They might have another medical issue. So the way I always say it, it's a guide. It's always a guide. Evidence-based practice is a guide. But does it apply to your patient? Is the data that's supporting it old, new, high quality? Is there going to be exceptions? Because, often we don't ask in research, we don't ask the right questions. So for example, if you have high blood pressure, you could be given a medication. You and me could be given an ACE inhibitor, which is a type of blood pressure medication. It's going to work for you, but it won't work for me based on my genetics. And we don't ask that question enough. Like, maybe it works well on specific groups, but not others. When you do a study, it's a general group of people. We're not asking ourselves, is there some nuance to
Sure.
that patient group, And so I'm giving a long-winded answer, but the gist of your question was that based on the best data we have available, we're using that to guide that decision as evidence-based.
Okay,
medicine.
that clarifies it for me.
Yeah.
Okay, thanks for that.
No.
Well, Phil, we're about an hour here, and I hate to make folks go longer than absolutely necessary. Anything else we want to address with Kwajo, or more questions to throw his way? I'm having a ball just hanging out.
Yeah, I think this is a great discussion, and yet another one that we will need to continue in the future as well. And like I said, I'm thankful that that we came across each other. Kwajo, I think, originally reached out to me, and I know my life has been better for it, and my thinking around medicine has certainly evolved from interacting with him. And I really, it needs to be said that, what Kwajo is doing in the system, he is a leader in the medical system, and he's trying to, enact this change. And we need more like him to continue doing that.
Oh, yeah, absolutely. All right, Kwajo, give us the how folks can follow you, get a hold of you, all that kind of stuff. We'll make sure this shows up in the show notes as well.
Before I do that, I just want to say, keep doing what you're doing, folks. It's changing lives. It's impacting lives, and we're gonna, like, one step at a time. We're making headway, and so I just really appreciate what you guys are doing. Phil, I had to step up and talk to you at that conference because I was so excited after hearing you on the podcast and hear about your own podcast. And Phil did make an appearance on our show too, which was killing it. But
I love it.
Yeah, you can follow me on Instagram, TikTok, YouTube, Facebook at Kwadcast. That's KWADCAST. Our show is called Solving Healthcare. And you'll find that anywhere you listen to podcasts, and go to solvinghealthcare.com. And we also, lastly, have a wellness community for healthcare providers because of all the burnout that we were seeing. So that's called solvingwellness.com. We also have a Facebook group with the same name, just trying to make a difference, put a dent in all of this, and we're trying to do it together.
Kwajo, it is such a pleasure to meet you. I hope we hang out together somewhere sometime, just as long as it's not Canada in the winter.
Oh my God, I'll find you. Where you at right now, Jack? Where you
I'm
at?
in Phoenix.
Oh my God, that's
that's
where we got to go.
We had a cool front come through this week. We're only going to hit the high 90s, so, and I like that.
Amazing.
All right. Phil, any last words before I sign us off?
Another great episode. Great conversation.
All right. Good stuff. All right. For Dr. Philip Ovadio, I'm so worried about pronouncing Kwadwo's
Man, you
name
got
right,
my name
that
isn't
I've got
even
yours
Ghanaian.
wrong. Dr. Philip Ovadia and Kwadwo Kyeremanteng. I'm Jack Heald. This is the Stay Off My Operating Table podcast. Subscribe, follow, all that kind of stuff. If you listen to podcasts, you know how to do this. You don't need directions from me. And we'll talk to y'all next time. All righty. America is fat and sick and tired. 88% of Americans are metabolically unhealthy and at risk of a sudden heart attack. Are you one of them? Go to ifixhearts.co and take Dr. Ovadia's Metabolic Health Quiz. Learn specific steps you can take to reclaim your health, reduce your risk of heart attack, and stay off Dr. Ovadia's operating table.